Thank you. So welcome to EMR Tips for Effective Use and Reporting. I'm Barbara McCaffrey with Toward Optimized Practice, and I'm here with Clinical Process Advisor Jesse Bondi.
Hi, everybody.
So we are going to go through some EMR tips for you today. The objectives of today's session are: during an improvement initiative, improvement facilitators will be able to identify the foundational components of using an EMR for screening and prevention, describe leading practices and identify pitfalls, and identify supporting resources for ASaP and next steps. Just so you know, we are going to take a vendor-agnostic approach to this EMR in that it will cite specific resources, but we're trying to capture lessons learned that can translate across EMRs for screening.
Okay, so we're going to start with standardization. And so for a screening program, we found that standardization is extremely important, and we want to focus on some quick wins that can be found from taking a standardized approach. So that would be processes for physician assignment and patient demographic validation, the recording of screening offers in consistent locations, for example, an observation template or field for just that information, and that could be around blood pressure or height and weight for discrete fields as well. Problem lists and keywords. And this will then make creating reports easier, and we'll have more accurate results if you know where to find the data that the report is pulling from. This brings us to panel. Paneling is very important for at the start and setup, so we want to be able to screen active patients and attach them to a primary care provider. We want to be, it'll help us to manage patient status, and if you take a look on the screen in the bottom right hand corner of this particular screenshot, you can see where the patient status has been highlighted as being active. It's there that we can assign or attach the patient status. You want to be able to verify demographics on a regular basis. And when it comes to regular, that is something that is to be defined within the clinic or the front office in terms of a time frame. And very key to the entire process is to remember to save all the changes you make on the demographics pages. And on the screenshot in front of everyone, you can see that in the top right-hand corner. So one of the key or foundational pieces around paneling is to remember that on a secondary benefit would be being able to contact a patient when there's a critical result from either a lab test or another diagnostic. You'll be able to contact the patients on a regular basis, knowing what their contact information is. So time is very, very important when it comes to follow-up on a critical result.
Yeah, thanks, Jesse. That is an easy secondary sell on well managing your patient panels in your office. If patient paneling isn't the first priority for the physician, selling them on the fact that you know who your active patients are, and in that case of a critical result, you can quickly contact the patient with that accurate information. Just a little comment about the screenshot you're seeing, which is from Practice Solution Suite EMR. Something that you don't see on the screen is a little validated button. That is tracked in PS Suite, but you have to go to another screen to get it. So you have to click on View and View Patient change history to be able to see that. Let's look at some other screenshots to be able to see what this looks like.
I'm sorry, I'm a little late coming in, but I didn't get an invite on my computer. How do I get onto the webinar?
Okay.
We will send you an invitation here shortly.
Okay, thank you.
What,
It's Krista from Wetaskiwin.
Thank you.
So Leanne will be doing that as we move forward. Thank you for letting us know.
Okay. I was in kind of a bad week.
Okay.
No, welcome to the webinar, Krista. So the screenshot that's currently up on the screen now is from the EMR Talon, and here we just want to be able to highlight really quickly how it's clear to show how to make a patient deceased here. And so if you look in the bottom right on the screen, it's highlighted, and I'm just trying to find it here myself. Is that?
Actually, deceased is not highlighted, but you can see where you can click on the box that you're confirming that patient is a member of the family doctor. You don't see a date in the field. This is a screenshot from a demo database, and it will date stamp when that patient is confirmed as a member of that physician panel. You can see it's highlighted where to attach the patient to the physician. It's highlighted where the patient is active or inactive. It's a little bit different, this EMR, in that it has patient is active or inactive. There's another button for deceased that's to the left of that. And there is another way that you can indicate the type of chart it is. And in the bottom right-hand side of the screen, you see the word type. And that is where you can create different chart types. So many offices, for example, will have an entire group of patients that the physician may see in long-term care, for example. They document those patient records in the EMR, but they don't really want to consider those patients as a member of the physician panel for screening processes, of course. So they can designate a separate chart type in this EMR for those types of patients, and then they can be separated out for reporting purposes, and you would not be doing your active screening on those patients.
Thanks, Barb. And so I think, and you walked them through like for long-term patients as well, long-term care patients. Excellent. So, okay, the next screen up is our MedAccess panel, and so here it shows when a patient, when the last time this page was clearly updated, and that's in the bottom left. You can see first appointment and then the last appointment, and when the paper chart was superseded. So you can see all of that information in the bottom left-hand corner. Just a quick reminder that in order to be able to update the patient button or validate that the demographics page was updated, you need to always hit the Update Patient button, which is basically in the center of the screen on the MedAccess panel. And again, a lot of the demographics page offers some similar functionality across the EMRs. Here you can see in the center of the page where to set the patient status for a MedAccess EMR user. You can attach your primary care provider in the bottom left-hand corner, and if need be, also who the referring provider is for the specified appointment. So, next slide. Yeah. Brings us to the panel from Wolf. The panel screenshot from Wolf. So some clinics here. Some of the key reminders or key messages to remember is that sometimes clinics do forget that the patient data verified checkbox needs to be clicked. Once that is done, it is timestamped. So if you're looking down in the just off the center there, it's highlighted and circled, the patient data verified. You want to click on that tick box to ensure that the patient demographic information has been verified. And it's something to institute within the front office staff, that you have a consistent process to verify patient data. And of course, you want to save all of the information before you move on to the next tab.
Thanks, Jess. Yeah, that's a really good point on this screen that you see that box. And we've visited clinic offices where they do that validation. It's part of their process, and they forget to check the box. So they never have a date stamp on when the last time that patient chart was verified. And as a consequence, too, you wouldn't be able to run accurate reports that way. Similarly, like, we won't go back, but on the previous slide, the MedAccess screen had that Update Patient button. And unless it becomes part of the process that the front office, that they click on those buttons, you lose the date stamping of when the last time the patient chart was verified and validated. And this should be a process in every front office of every family practice clinic. So next we're going to look at searching. The searching functionality is very important, and in ASaP at the beginning of the project you want to be able to produce a list of patients, and you want to search for active patients attached to each provider, and you're going to use the practice search or the query tool in the EMR. And in this case, here's a screenshot from Wolf Practice Search, and you're going to pull out the primary care provider, set in the age of the patients, and be able to get this data. Just to tip in using Wolf is you do have to click that Search All Patients button in the top right-hand side, upper right, to make sure that you're pulling that unless you happen to be an administrator. So once you pull all your patients and you have that list and can identify your patient panel, the next thing you're going to do for ASaP is specifically get those patients 18 to 74 years of age, and that will be informing your chart review. The next screenshot is an example from MedAccess, and again here you can clearly designate in the practice management reporting area of the EMR those active patients attached to the doctor, and you're going to specify the date range. And you can clearly see here where you can export the data, and that's another option in clinics. If you want to be able to manipulate the data in another tool such as Excel, you're able to do that.
Okay, so this brings us to the chart review. And so in preparation or for conducting your chart review, you want to be using the screening offer documentation sheet, and we should be updating our website, the top website shortly, to ensure that it is on. Our new offer documentation sheet is on the website. And so during the chart review, this is an opportunity for you to be able to record new places where screening offers were found, because it will inform decisions regarding the potential need for standardization, and it will inform the screening process redesign. So when you have the opportunity to look at that screening offer documentation sheet, which is going to be posted on the next slide, you'll have had the chance to document where physicians within the clinic believe they are actually documenting their all of the maneuvers for ASaP. So here's an example of what the screening offer documentation would look like. So you have the pre-chart review. That is the conversation you're going to have with your clinical providers in the clinic around where each of the different maneuvers are being charted. So that would be before you start your process. Then you also want to know which of the members of the clinic are entering information for each of the different fields. And then you want to be very diligent in your actual chart review observations to be able to document where some of the information is being found if it doesn't align with what the physicians have told you prior to conducting your chart review. So I just want to run through a little bit of what do all of the columns mean. So we have the pre-chart review, and this is the location in the patient chart where the clinic team indicate the screening offers are being documented. This is then provided to the IF by the team members who are involved. So this will take a little bit of sleuthing as you chat with members of the clinic team. During the chart review, that column is where the offers for the screening were actually found. This information is observed by the chart review as they go through the chart review process. And again, who enters the information will identify the different members or categories of the clinic team that are responsible or involved in documenting portions of the screening maneuvers for that patient chart. And then how to use the information. It'll aid your chart review, so you'll know where to look initially when you open up the chart, so you can find offers of the documentation. It'll help to inform the facilitated discussion around standardization. It'll document or highlight the need for initiating an improvement process, as well as inform the improvement process itself. And it will help with the improvement team documenting and building the case when facilitating this conversation within the clinic and the organization. Anything that I've missed, Barbara?
No, but I do want to add that, like you said, if you can present this information back very objectively to the team, so to the physicians, to perhaps those in the clinic that document the scanned documents, and add the keywords and say, well, we're finding when we look for reports for colorectal cancer screens that they're named 10 different ways in the clinic, and that will be a challenge for us in finding the information because they're not named all the same way. So if you present the information back objectively, this is what was found, then it can very much be an informed information for the team that's working on improvement. So in terms of conducting the chart review, within the EMR you're going to have different areas where you'll find different information. Forms are a great source of information as they're a document of the offer. And if the forms are all completed in the EMR, which many clinics do, that's a documentation of the offer. And you have different types of forms. You have the MAMOs and PAPs as well as the lab forms. Letters are a way that you will find documentation of offers of colorectal cancer screens. And results are another type of documentation of the offer. It's the offer that was completed. So if you look for incoming labs, mammography, or PAP tests, as well as scanned documents, these will be indication of offers. The other place you will find it is in standard data fields, and typically good examples of that are height, weight, blood pressure. You will find the lifestyle screens of exercise, alcohol, and tobacco. These ones can be in really various areas of the EMR. Some have a lifestyle section, some have a risk section, some have a personal history section. And this is where you can find that information. And vaccinations may be in a separate vaccination area. I want to highlight talking about incoming scanned documents because this can be a real opportunity in the clinic during ASaP to identify how the clinic is attaching keywords to scanned documents. And this is where, for ASaP, you'll find the mammography and colorectal cancer screens. And somebody in the clinic, or a number of roles, depending on the size of the organization, will be naming these as they attach them to the record. And ideally, you should have standard naming conventions and set keywords. Now, this is a cost benefit. I was recently visiting a clinic, and this was an issue that they were dealing with specifically for ASaP. The MOAs who were naming the incoming scanned documents were saying they just wanted to do it as fast as possible, so they all were free typing it. And while it appeared to be very fast for them to be doing that on the input of the naming of the documents, they were all doing it differently. And it was really becoming a problem. If they realize that they have a set list of keywords and it's locked down and they might have to use a drop-down menu, it may take a couple more seconds, yet the benefit on the other end is certainly for screening and data analysis. But they might not understand that. So it was becoming a issue that the clinic was dealing with in terms of informing those individuals who named the incoming scanned documents the benefit of them choosing a standardized list. Something that they could explore, and they hadn't done it yet, was working with macros, in which case the MOAs would have a few keystrokes that would then populate some standard lists. The other option was locking it down, and then they would just choose from the drop-down. But that was a discussion that they need to have. It was definitely a change management discussion, and the people that are putting in the information need to understand the benefit of getting it out in a standard way. Another important thing is that some tools that we're going to be talking about won't work unless that information is put in a standard way, in which case it could feed something that we're calling a flow sheet, and we'll show later on.
And that brings us to recording the screening offers. So you do want to be able to have the conversation around charting consistently within the charts themselves, whether that will be by provider or will it be across provider. So that would be by on an individual physician basis, or will all physicians within a clinic adapt or adopt the same methodology for charting screens. Some of the tools, you have designated fields, like one of the biggest examples is blood pressure in the blood pressure field, or you can record flus in the vaccine section. We have forms to use, so top has the HSI, the Health Screen in Action template. Several EMRs do have this form, but I just want to highlight that it may not feed into a flow sheet in and of itself. So it's very similar to just writing into or handwriting into a document that you'd have on paper. It's there to store the information, but it's difficult to feed into other or automated workflows within the EMR itself.
Yeah, just to add to that, Jesse, if clinics are using that as a form, it's a great way to record the information, but it's like a lab requisition form in the EMR. It's just a stored document, and it won't be easy to feed that form into other areas of the EMR.
Okay, thanks, Barb. And so another tool would be templates, so either observation or visit templates, depending on the naming convention of your EMR. And for the EMR tell-in, they have what's called a poem, and we'll be discussing the poem a little later on in the session today. If we look at MedAccess, they use goals, and for Wolf, we want to highlight the manual lab results.
And yeah, before you get into some of the examples, some of the EMR providers are working with us at TOP and creating special ASaP templates. So Wolf has it, and they are ready to get that out to clinics and let clinics see that. And that Wolf ASaP visit template will also work with a flow sheet. HealthQuest is working on one as well. And we have the one from Tellen that is called the poem, and they are adding all the maneuvers that currently aren't into it to make it fully capable for ASaP.
And just before we move on, I just wanted to add a note. For the Wolf template, they are still looking for pilot sites, correct, Barb?
Yep.
So if anyone on the line is using Wolf and would like to act as a pilot site, please contact your CPA, and they will get you in touch with Barb and the vendor to get that template out to you as soon as we can. Okay, so here, recording visits in the template. This is a MedAccess template. So I just want to highlight, as you're going through and adding blood pressure into the field here in the center of your screen, where it's been highlighted, you can add another observation, and so you can just click on the binoculars there and type in another observation that you'd like to add, and that would be something like, what could we add?
A vaccination.
A vaccination.
You could easily add vaccination by clicking on the binoculars, or if you were doing a diabetes exam, you could click on the binoculars and pull up a diabetes observation template at that time.
Excellent. Thanks, Barb. And the next one brings us to Tellen, and this is an example of their poem template that they've created, and this would be for use by their POET, which is their proactive office encounter technician. And so you can see within the template there that there's a process in place where you can document whether it was discussed, whether the offers were discussed, if it was declined, and if the requisition was given and provided to the patient or not. The other thing to highlight is just off to the right-hand side, it gives you a field where it says poem history, and that would be any of the templates that have been offered in past visits to patients. That's where you would go to look at some of the information that is stored in those templates from past visits. And so up at the top right-hand corner is where you find the date of the form that you're currently looking at. So have I missed anything there, Barb?
Just wanted to add, like as I mentioned, Tellen is adding the maneuvers you don't see on there that are part of ASaP. There's a few that are missing, and they are being added in, as will the fit test when it becomes available by AHS before year end.
Excellent. Now we come to the PS Suite, and here same thing. Here we're looking at some of the behavior and behavior assessment. So if we're looking at smoking, it's really quick. You bring up the screen. You can look to your left-hand date there, to the left-hand side of the screen, and it can verify by just clicking on the button that yes, the patient is still smoking a pack a day. If you tick the button, you've now documented that the patient is still smoking and that the conversation is taking place, and you can continue to proceed from there.
And that's another date stamp, so that you've got validation of when that was last checked. So we're going to go into monitoring. So if you recorded screening offers in the clinic, and how can you monitor them? So we'll look at some tools such as global reminders, rules, flow sheets, and templates, again looking at the POEM template. So monitoring, looking at, this is a screenshot for Practice Solution Suite. So all of the risks are on this main page of the patient, where you can easily view the risks, and you can see all the screens when they were last offered to the patient, and document when, the patient was just informed, and it will show up red when it is overdue. It's a very easy way to manage that in PS Suite. PS Suite, you can also make a flow sheet, and it's fairly easy to make a flow sheet and to look at where the screening offers are documented, and it will pull it together, and this is a view for one patient in the case here of Mr. Mouse. And at a glance, over time, you can see how the offers have been documented for that patient. In this case, you will see, for example, that the clinic is pulling up the information on where they are documenting it. So it was a custom-built flow sheet. And because they were documenting smoking and alcohol in notes, it was actively searching in those areas to create the flow sheet. This next example is rules in Wolf, which is, it can be a passive technology in that the rule will pop up red if it's overdue, and the user needs to click on the rules to see what is overdue. So if it is not in the role of the user to act on the rule, then they don't have to click it. And it's not an in-your-face alert that they're constantly trying to deal with. I also wanted to highlight on this page that you can clearly see that there's a place to document vaccinations in Wolf. And another example, again, in monitoring the screens. As Jesse mentioned, this is the POEM template for TELN. And there is nothing here in this example, but if you look in the POEM history, this is a way that you can monitor over time to see the offers of screening to that patient by clicking on the previous POEM templates. And just an FYI too, that TELN is working on the reporting from this template. It presently exists, but it is actually in the state of improvement, which is a good thing to hear. And finally, another way to monitor where patients are for their offer of screens, this is from MedAccess, and it's using the goals technology. So the clinic does have to have goals turned on. They'll likely have some setup if they already haven't done it. But this is a great way to monitor goals at an individual patient level. Something I want to point out to MedAccess users is with the new dashboard technology in MedAccess, it can be configured for the individual so that they can see goals from their dashboard. And depending on the role and the workflow and what role that individual is playing in screening, the ability to see it from the dashboard would be very convenient. But you can see that goals will show for the screening maneuvers for that patient, if they're meeting the target, the last time it was recorded, if it's overdue for the patient, and it also tells you if the goal is met or not. Okay, Jesse's going to tell us about risk calculators.
Okay, so there are risk calculators that are built into many of the EMRs, and so we're going to talk about the Framingham CV risk calculator. The EMRs have built it in. It's a 10-year CV risk calculator. It is just a tool, and it does not stamp the result directly into the chart, and we want to be able to highlight that to you on the phone, that it must be manually noted inside of the chart. So when the physicians go in and utilize the calculator, that the results need to be charted at some point. So that process needs to be discussed and then finalized within the conversations within your clinic. Within other EMRs, and now before we move on, I just want to verify, is that for all EMRs or is this for a specific EMR that we're talking about?
No, they're different, and this is becoming, so you have to find out what it is in the EMR, and actually we're realizing too it's changing with releases as well. So some is just a tool, you can pull it up, you use it, then you have to note it in the chart. Other EMRs, it actually stamps it in to the chart for that patient, and it remains part of the chart. And that's important for the clinic to note. And I actually anticipate probably by March we're going to, the EMR providers are changing this, so you got to stay on top of it for your product.
Okay, thanks, Barb. And so some of the other risk calculators that are out there, there's a diabetes risk calculator, and you can find that on the CanRisk website. there are patient patient surveys. We move to the next page. This is an example of a CV risk calculator from the PS suite. It does not stamp the chart, but the next release, as Barb has indicated, for many of the EMR vendors, the next release from PS suite specifically will. And one of the key things that I wanted to highlight here is that on this screen, you notice that there are movable tabs. So when the physician brings this screen up, he can actually demonstrate to the patient that as different factors change, either cholesterol change, what the impact will be on the cardiovascular risk. And in the next build, as I indicated, there will also be a function that will return the settings back to the actual status of the patient. So they can use this as an example to indicate what happens as blood pressure changes, whether it increases and can become a bigger risk factor, or what would happen as they begin to normalize their blood pressure and what the effect is on their CV risk going forward. Here's an example from Telen. It has the Framingham button, and this one does not stamp the chart. So as you can see,
Oh, it does stamp the chart.
It does? Oh, sorry. This one does stamp the chart. My apology. This one does stamp the chart. So as Barb had mentioned earlier, the EMRs are at different levels. Some do date stamp and others do not. So we just want to highlight that with this risk calculator it does, and it's my apologies for the blurriness of the screenshot, but it's there in the center of the field, very visible to the physician. So when they click on it, they'll know what the risk calculator is for cardiovascular disease.
Okay, we're going to just go into some examples at this time of some clinic practices across Alberta that have had mature and advanced screening programs. And while there's certainly a lot to talk about with these examples, we're going to stick to some of the components that really relate to what they're doing with the EMR. The first example is with the Edmonton Oliver PCN, and they have a very mature screening program. And one of the philosophies that they've taken to their approach is that it is physician-driven. And when it comes to EMR use, they are willing to meet the doctors where they're at to make it work. So they do not look for a lot of standardization because their screening coordinators are really going into each record for each patient for the screening process. They use the communication tool in Genoki, and they found this very helpful because the PCN screeners are not physically located with the physician team that they're working with, which is an MOA and a physician. But they use those communication tools to go back and forth and send notes within the EMR to communicate information that's relevant to the MOA or physician. An example be that the patient is coming in, and the screener noted that when they had the conversation with the patient on the phone, and they're sending a note to the MOA that's relevant to screening related to that patient. Because they are a phone program, they contact the patient first by phone, and they have that conversation about screening. They do use the EMR to fax the forms directly from that patient's record to the investigation site, and they find this very helpful. They also find remote access helpful because that screener is a remote member of the care team, and they are not co-located. They've also, because they're meeting doctors where they're at, they have become very good at learning where each physician is documenting, and they are able to work with the team. Each screener is designated to a team of physicians. One thing I wanted to point out about NetCare, while we know for ASaP, screens that are offered in NetCare don't count for the chart review, this clinic is using NetCare to view for screens that might have been completed by other providers, and they might have seen that by the patient having a referral letter to another provider. So they're looking for those, but they also very diligently use this to manage the deceased status of the patient. So they're looking for that. They want to absolutely be certain they are never calling a deceased patient, so they use that NetCare information to manage that. I realize we got a spelling error on the next line, but that's important. Okay, that's the Allen Clinic. So they have a very well-established program. Another example is in the Westview Primary Care Network, West Grove Medical Clinic. Their approach too, so they have a clinic manager that has become a Telen super user. Really important that they understand the functionality of the EMR. They are very diligent in managing that patient attachment to physicians and managing the status of a patient as active and inactive. So they have proactive encounter technicians in the clinic. They do use that POEM template. They record and monitor the screening maneuvers for that patient in that template. They're recorded by date. They're able to look at the history, and they're also able to pull the lab data. Now, importantly, they also use the query tool. So they do this to audit the charts for the screening data. They send it to a database, and their first point of contact with patients is by letter. And they send the letter to the patient with the recommendations from that physician, and it's a physician letter, and that initiates the process. Now the poet is going to monitor it in the EMR, because the letter said, if you aren't going to complete this requisition, please call us, or we will be contacting you back. So the second contact is by phone, where the poet is looking back in the EMR to see if the screen was completed, and then having the appropriate conversation with the patient. And they're also very quickly in doing that as well. They did want to note that they are monitoring if critical intervention is needed for those patients. Another example is RIMBY, and they use PS Suite EMR. They spent quite a bit of effort on advanced training to develop their super users in the clinic, and that was important to them. Again, managing that patient status and assignment, using the demographics diligently in the EMR. Their strategy is using global reminders, and they've set those reminders across the clinic, and that is on the main patient page, and they're able to see the screens that are due for the patient. They're quite systematic at recording problems, risks, and immunizations systematically in the EMR, and they use that search tool to produce lists, which they use for outreach screening by the screeners in the clinic. Another example of a clinic with a very mature screening program is the Tabor Clinic in the Chinook Primary Care Network. Some of their EMR strategies include that they have spent a great deal of effort. The clinic manager is a Wolf super user, knows that product in and out, and is able to mentor everybody in the clinic. And the processes in that clinic include diligently managing their panels and the patient status. They use that validated box that is on the patient demographics page quite diligently. Now, they've found a way that they can manage their panels, and they've had to create another doctor, which they call ZZ Doctor. He appears last on the list. And they attach patients that are not permanent parts of their patient panel to that physician in the EMR. So they do not come out for reports or screening, because they're doing quite a bit of that in the clinic. They actually are producing run charts through the EMR by physician on a monthly basis, so each physician knows their screening rates. Something else they've been diligent at in Tabor is the standardized problem list and document keywords. They're using the rules in the Wolf EMR to manage and monitor screening for each patient. And they use both opportunistic and outreach methods at this clinic. The method actually involves that each team is an MOA and a physician. The physicians do work outside the clinic at the hospital, and during that time is when the MOAs do much of their screening outreach work. And the MOA owns it for that physician, and they want to keep on top of it, because they know if they don't, that just creates more work for themselves. They record their screening offers as manual lab results in Wolf, and they've been doing it a very long time, and they haven't had the advantage of tools such as the new ASaP template that's coming out. And they are very diligent as well at using that practice search tool, and that's how they monitor their screening offers. And the fifth example today is the Department of Family Medicine at the University of Alberta. And their approach to using the EMR and improvement is integrated. They have quality coordinators that work in each clinic, and because they are a teaching clinic, they not only understand the EMR, they play a role of an improvement facilitator within the clinic. And they also are coachers, because they have residents coming through the clinic all the time. They coach those residents on using the EMR, but they're also there to coach the preceptors. Again, managing the patient panels and the care teams that are attached to each patient are completed in the EMR. Managing the patient status as well on that main page in MedAccess. They have standardized problem lists that make sure that they aren't using other words that would make their searches more challenging. They are recording their data in observation fields, pretty much all in templates, and that allows it to work with goals in MedAccess. And that also, use of goals, allows them to use the practice management reports. And they use those to monitor screening rates. And they, too, produce run charts on a regular basis by physician, and they actually are posted in the physician, in the office, where they will see the run charts of the different providers, and they share that information for improvement processes. So before we go into Q&A, just a reminder on some of the places where you can get help. And something I want to point out, all those examples that we just went through, the clinics all used time with the EMR vendor to improve things. And having that relationship with your vendor is key. They can provide training, of course, help desk support. An example is one of the providers, Tellen, is going to be starting monthly webinars for all their clients if they want to tune in and just get some tips on using their EMR better. And user group meetings can be very helpful. We have one coming up next week, next Friday, with Wolf in Banff, and that's our annual user meeting, and there's lots of opportunity at the user meeting to get one-on-one support. As far as ASaP goes within the scope of using the EMR for screening, we're here to help. POSP is offering their services till January 31st for 2 specific areas, the peer mentoring program and reimbursement for advanced training. And there's the community of practice, and some of the most effective EMR users in the province network with other EMR users. And for the purpose of ASaP, we can network and reach out to each other through our EMR site, and that's one way that we can collaborate. Of course, at top, your clinical process advisor is here for you, as well as myself in my capacity. So before we conclude off, we want to be able to open the floor for questions. If you ask it the question on the phone, it's going to be on our recorded webinar, and your other option is to put it in through the chat functionality. Yeah, if it's on *6 if you've muted your phone, and that's how you can unmute to ask your question. So I take it that we don't have any questions at that time. I know you probably have very specific questions about the products that you're working with, and to ask those very specific questions, you can do that again through your clinical process advisor, or contact me either through Yammer or through your CPA. So I want to thank everybody on the line for your participation today, and wish you a good afternoon.
Thanks, everybody, for joining us.
Thank you.
Thank you.
Thanks. Great webinar.
There we go. And that's done.